So it takes me great honor to introduce the next speaker, Dr. Suebpong Tanasanvimon from the Chulalongkorn University in Thailand, stronghold of the university for a long period of time, and really world authority on the fluke of the liver-driven cholangiocarcinoma. We are very thrilled because, as you can see, learning about the disease that might pertain to somebody who is, for example, located here in Salt Lake City would probably require an understanding of the disease in other parts of the world. And for that reason, I think that interaction between us globally and among all the investigators has been quite valuable. And thanks to you for taking all our calls early mornings every now and then. But please, by all means, Suebpong, please.
So, good morning, everybody. And first, I'd like to thank the foundation for inviting me here and the opportunity to let me give a talk about the fluke-associated cholangio. So, my topic today is the Fluke-Worm related cholangiocarcinoma, the fact. I believe that everybody in this room have heard about the liver fluke. And liver fluke is probably associated with the cholangio. You probably read a chapter of a book about cholangio and read some part of the risk factor. And they always say that liver fluke is an important factor for the risk factor for the cholangiocarcinoma. But what is the liver fluke and then how is it related to the cholangiocarcinoma? Okay. So I will go over all this topic that first I think we should know about the liver fluke first. And then we should pay attention if it really cause the cholangiocarcinoma. And can we control the fluke if it really causes cancer? And finally, I will mention a little bit about the if it did any difference between the fluke-associated and non-fluke-associated cholangiocarcinoma. Okay, so the liver fluke is a foodborne trematose that habitat in the biliary tract of the vertebrate. So far there's at least 13 species of the liver fluke that recover in a human. And here are the three most common flukes that are found in human. The first one here, is Opisthorchiasis viverrini. Second one is Cholangiocarcinoma, and the last one is Opisthorchiasis filinis. So it looks similar, but it's a little bit different in the structure, and of course it's different in the endemic area. So these two is endemic in Asia, and this one is endemic in Europe. And only these two have enough evidence to call that it is related to the cholangiocarcinoma. So let's see the global distribution of the liver fluke infection. So in this picture, they depict it as you see in this orange color is defined as the area that have the high prevalence of the liver fluke, and the white color is there's no transmission at all of the liver fluke in this area. So then you see that the orange one, the most area that have a high prevalence of the liver fluke infection is around here. So here is my country, you know, Thailand. Yeah, it's around here. It looks very difficult in this map. But it's here, I write, I see, this is Thailand. And the orange area is two parts of Thailand here in the north and the northeast. And here, the line here is the river that named Mekong River. So we call this area is a Mekong Basin here. And this is Thailand, no, okay. And here is Laos, our neighbor. So northeast of Thailand and Laos is an endemic area of the liver fluke that named Opisthorchiasis viverrini. And there's a line, oh no. There's a line here that it's kind of a line that the area that the Cholangiocarcinoma sinensis are endemic around here in the north, and the Opisthorchiasis viverrini endemic around here at the south. So the Cholangiocarcinoma sinensis endemic in this area, especially in the China and in Korea, that had been reported. And how much of the problem of the infection? Here is estimated number of infected patients. So roughly for the Cholangiocarcinoma, China combined with the Korea maybe around 15 million of patients that are infected by Cholangiocarcinoma. And for the Opisthorchiasis viverrini, only in Thailand and in Laos, it may be around 9 million people infected by this liver fluke. So how people get this infection? So we need to know the life cycle of the liver fluke. All liver fluke have the same life cycle. So the human is the definite host of the worm. And at first, the human just excrete the liver fluke egg through the feces, and it just get in the natural water resources. And this egg eaten by snails, and it just transform to the cercaria and get out in the water as a free living, and this free living invade to the fish. It just invade and insists in the skin and the meat of the fish, and then it's insists in the form that we call the metacercaria, which is an infective form of the liver fluke. And people eat this fish and get the worm. So when it get into the bowel, it go to the duodenum, the small intestine, and exits. And the metacercaria just travel through the ampulla of water and get in the biliary tree. And its habitat in that biliary tree, especially in the intrahepatic bile duct. And it's going to be there maybe 10 to 20 years. It's has been reported that for the OV, the Opisthorchiasis viverrini, maybe around 10 years, but for the Cholangiocarcinoma, maybe up to 20 years in human. Okay, and one common thing that how we get this infection by just eating the fish. So the thing is the habit that how we eat the fish. People in this area, they eat the raw fish, but it's a raw freshwater fish. When you eat it, if you cook it, you heat it, the heat just kill all the parasites or the worm, and you will not get any infection. But it's just because the habit of the people around this area. It's the same as in Thailand, Laos, even in China or in Korea. They have some habit to eat the raw fish as the freshwater fish. So they get this infection. Okay. Then once you get the infection, what happens? Usually both for the Opisthorchiasis and the Cholangiocarcinoma, usually people doesn't have any symptom. They just maybe have some abdominal pain or very mild. And the pathology that they found that for the early infection, there's usually nothing. Maybe some acute inflammation in the large intrahepatic bile ducts and the portal connective tissue. But for the chronic phase, you can see that the hyperplasia and adenomatous formation of the bile duct epithelium, and also the periductal fibrosis or scarring in the around the bile duct. And this gonna take maybe 7 to 15 years to develop all this the pathology. So this is the thing that why the parasite can cause the cancer. As you know that if we know that this infection happened and then we treat it, then we will not let this process to go to the chronic phase and finally develop to the cancer. Okay, So, but as I said, that there are several million of people infected by this parasite, but just a few or certain subgroup of patients that finally develop cholangiocarcinoma. So how is related between the cholangiocarcinoma and the liver fluke infection? It just come up to attention because of the epidemiologic data at first. That as you see here, this is the global incidence of the cholangiocarcinoma, and you see here that this just a very high incidence in Thailand and in Korea and China. Which is the same area that we have the liver fluke endemic. Yeah. So we just go deep to the Thailand data here. That if you see, if you see here that in Thailand, the orange area here is still the area that have the liver fluke infection, and the area here in Thailand in the central and the south, actually there's no liver fluke infection. And look at the incidence of the cholangiocarcinoma here. So in Thailand, one thing that you need to know is when we report the cholangiocarcinoma by the cancer registry in our country, they just define it as the liver cancer. So the liver cancer combine the hepatocellular carcinoma and the cholangiocarcinoma. So when they report this, the liver cancer, it have a very high incidence in the northeast of Thailand. Here is around 70 to 80 cases for 100,000 person years. It's the highest liver cancer incidence in the world. But the red one is a cholangiocarcinoma. This is a different thing. It's a different to all over the world that the most common liver cancer in northeast of Thailand is a cholangiocarcinoma, not the hepatocellular carcinoma. And this the summary of the finding that I just said. So here is the SCC and the cholangio here. You see here in the northeast, the concan is a province in northeast that almost 80 or 90% of the liver cancer are the cholangiocarcinoma. While other area, even in Thailand, most common is a hepatocellular carcinoma. So it's just that because of this epidemiologic data, it just come to the attention that maybe it's related between some relation between the cholangiocarcinoma and the liver fluke infection. And there is two epidemiologic study. One is a case control study from the hospital-based patient population, and another one is cross-sectional study from the community-based population. So we can detect the liver fluke infection by do the serology to see the antibody to the parasite, and another way is to detect the eggs, the liver fluke eggs from the stool. So these two studies do both, but it's come up that the people that have antibody to the liver fluke, or people that have been proved that to have infection by discover the liver fluke egg, have more odds ratio to have cholangiocarcinoma than the people doesn't have it, and it's maybe around 3 to 5 times compared to the people that doesn't have the infection. So we have the epidemiologic evidence that the liver fluke is associated with the cholangiocarcinoma, but how is happen? So this is one classic animal model for the liver fluke and the cholangiocarcinoma that have been quoted in several articles. This animal model was done by the researcher in the Mahidol University in Bangkok. It's just back to 1978. They just do the animal model in the hamster, and they have a hamster, maybe the 80 hamster, and they divide it into 4 groups. The first group have a no treatment, second group have a nitrosamine treatment, the third group have the metasaccharide treatment, and the fourth have both. And at the end of the study, they found this. So for the first three groups, there's no cancer developed at all. Either no treatment, either you give only nitrosamine, or either you just give only the liver fluke infection. There's no tumor. But if you have 100% of the hamster have a tumor. So we know that this nitrosamine is a carcinogenic factor, but only the nitrosamine cannot make the cancer too. So the thing about the nitrosamine is also the thing that happened in Thailand. We know that nitrosamine you can find in the many fermented food products, but as I told you that the people that are eating the fresh, the raw fish in the northeast, they do have some food staple, and the dish that they do, that they put some fermented fish that have been detected the nitrosamine that are much more than the average that should be. So based on that epidemiologic evidence and the animal models, the IARC have concluded with this that there is sufficient evidence in human, although it's limited evidence in the animal model, that support the Opisthorchiasis and viverrini and the Cholangiocarcinoma as a carcinogenic factor to the human, and its category is as the carcinogenic factor group 1. So I think we have enough evidence to say that the liver fluke is a kind of carcinogenic factor to the cholangiocarcinoma. But how it happened? Actually, it's still unclear that how it happened, but we believe that there might be three mechanisms that the liver fluke can induce the cholangiocarcinoma. First, maybe this, that the liver fluke itself, when it habitat in the biliary tract, it can cause the direct mechanical injury. And this can go to the wound healing process and make some chronic inflammation. And together that can cause some DNA damage and promote the cell that prone to develop to the cancer. And another thing that have been extensively studied by the researcher in the Konkan University, that the excretory and secretory product of the parasite. So they just have a secretory or excretory product that extract, and then they do an in vitro and in vivo study and show that some of the product have some substance that can promote the anti-apoptosis and promote the DNA damage. And finally, all this together can have a DNA damage and a fixed genetic alteration and develop to the cholangiocarcinoma, which also include this, that not only the parasite, is also because that they have some nitrosamine, exogenous nitrosamine that they eat, and then together they cause a cancer. And here is the proposed that they propose that the cancer may have developed beginning from the OV infection here, and then have some inflammation, and the chronic inflammation just confined to the duct and induce a periductal fibrosis, and go to the advanced periductal fibrosis and with other abnormality and develop to the cholangiocarcinoma. The thing about this is they have extensive study about the periductal fibrosis, and they believe that this periductal fibrosis is kind of the precancerous region for the advanced periductal fibrosis to the cholangiocarcinoma. And this can be detected by the ultrasound. So you can just go to do the ultrasound in the patient that have an OV infection, and then if you detect this may be a group that have a high risk to have the cholangiocarcinoma. And recently, what they found is this finding in the ultrasound is correlated with the IL-6 level in serum. They found that IL-6 is 8 times fold in advanced periductal fibrosis. So this might be one thing that we can do to have an early detection for the patient that have an OV infection. So I think that we know that if this infection can cause the cholangiocarcinoma, can we control it? If we just control the infection, then we can prevent the cancer. So here is the thing that when I say that the people infected by just eating the raw fish, what we doing is we just stop eating that fish. So that's it. You will not get any more infection. But it's not just that easy. It's because that this is the way that people do. In this area is the agricultural area. People just go to the farm, and then what they having at the farm is this food. So what is it? As I told that this what we call that this is very popular dish for these people. We call in Thai is a koi pa. Koi pa is a raw freshwater fish that they just cook. They didn't cook it. They just mix up with the seasoning thing and they eat. And also they have this. This is we call prala. It's a fermented fish. They just put the fish in this container and put some ingredient, and they wait several weeks to months, and they just use it as a food staple. And these have a very high nitrosamine content. So these together, it just made the people have more prone to the cholangiocarcinoma. And this is a thing that we have been done for, I think, 2 or 3 decades. We just have a program to stop eating raw fish, but it's not success with just this poster. So here is the history of our opisthorchiasis control in Thailand. You know, actually the first start for the opisthorchiasis is just supported by the US government. It started in the 1950s, and they have some unit. What they do they try to have an early diagnosis and treat the OV infection. But it's just confined in some area of the Northeast. Finally, in the 1980 until the 1980, that the researcher in the Mahidol University, they found that just giving 1 dose of the praziquantel, the anti-human antibiotic, just only 1 dose, you have a very high cure rate. How high it is more than 90%. You just eat 1 dose, you can cure the liver fluke infection. So that triggered the program in our country that it's just a pilot program in the Northeast, and finally it's been the national-wide program. What they do is they just they just try to detect the infection and treat it. And what they have been done for 10 years is 7 million individuals have been examined for the have a stool examined to look for the infection, and 2.3 million cases have been treated. And with this program, they have this result. So you just see only here. This is the OV infection prevalent in the Northeast, the endemic area. So it starts with around here. So 1/3 of people around there have an OV infection. And as I told, until 1980, that we have known that the praziquantel can cure the liver fluke infection. Then it just dropped drastically to maybe just 10% something in the 1995, and it just come up again in 2000. So we don't know what happened here, why it's come up again. What one possibility is here is it's just the time that we have an economic crisis in Thailand in around 2000, and the government have a limited budget to support this program. But that thing is not that most concern for us for now. But the thing for now is here that in 2009, even we say that now we have OV infection much less than before. In the nationwide survey, they found this, that the OV infection prevalent in some area, in some villages, that we know is a really high prevalence, is still high. How high is it? It's 85% of patients, or 85% of people around there that still have infection. It's the same number that we had 50 years ago. That's a kind of shock for us that what we're doing now. So in the area that for the nationwide program, it look good, but for some area it's still not good at all. And another thing that is contradictory for what we have done is the thing is they have a few reports of the study that to see that if the people get a praziquantel, then how it's going about the cholangiocarcinoma. And here is that this is the hospital-based matched case control study. And then they found that if the patient have more treatment with the praziquantel, as I told, they just have only one dose. And if they have a repeated dose, the thing is they have they have a higher risk to have the cholangiocarcinoma. This is a kind of strange, but it's of course it's not because that the praziquantel causes cancer, but maybe because the reinfection. So it is a thing that this also correlate with the consumption of the raw fish and the fermented food here. Is a consumption of the raw freshwater fish is also more in patients with they have the praziquantel. So this is a thing that happened with this program. So the people receive the praziquantel, and then what they're doing is once they cure from the infection, they just eat the raw fish again, and then they get the infection again. So they know everything. They know that the infection is not good. The raw fish can cause infection. The infection can give to ultimately to the cancer. But what they know, another thing is we can kill the infection. And what they said is it doesn't matter that about eating. They have the thing that can kill the infection. So it's kind of we give some wrong message to our people that we have another drug to help you. You can keep your habit. You just take the drug and everything should be all right. But this is a wrong message for them. So now we need to think about what we have been done for the 2 or 3 decades. So this is the initiative project that initiated by the researcher in the Konkan University. So they just think again that what's going on, and then they propose this. So based on this, one main reason that they think that the OV control program have been failed for the past decade is we cannot change the raw attitude of the people. You can see here, they eat the raw fish, but look at them. They're very happy. They are very happy eating this. So how can you just get rid of this? So it's just very difficult. So the thing is, the concept is, they say, so that this initiative group, they say that maybe we just let them do it by themselves. The thing that the past we done as the government, the authority, the public officer just go down and tell them, this is bad, you should not do this. If you have infection, we're gonna treat you, but you should do it again, but they not listen. So they propose this to do. This is the program that they do. They're gonna do the comprehensive thing. They do the treatment. They still detect the infection, still treat the infection. But what they put more effort is they're gonna do the intensive health education with this. So instead of go to the people and teach them, they just have some health volunteer from the village and let them teach by themselves. Here, the people at over there and treat these people, so they can talk more friendly. Some say that what we have done is kind of a sensitive issue for the area. So maybe it's better to just done by the people over there. And the new target group for this strategy is the children. So another fact for the liver fluke infection is you can find it since you are children. We find that 9% of school children have a liver fluke infection. So they focus on the school too, and they teach the children. And the thing happened here is for the pilot program, they found this. From the 67% of the OV prevalent and 9% of the prevalent in children. Within 3 years, the OV prevalence just dropped to 16%, and now it's undetectable. And it's kind of now they say that it's very rare for the reinfection in this area. And also the school now they have this liver fluke free school. They say that in that area, the pilot area, they have a certified this liver free school for all schools in this area. And the most interesting thing in this is what they had done for the people. They also changed the ecosystem in that area too. Before the program start, the 70% of fish in this area have been infected by the fluke. But at the 3 years after that, only 1% of the fish infected. So either we can cut that the life cycle so we can control the infection. But the thing is, this is just only the one village, and you can imagine if you want to do for the million of people, it's much more difficult to do that. Okay, so how about the cholangiocarcinoma? Here is the prevalence of the infection as I shown you. It's just going down to lowest in the maybe 2001, and it just come out a little bit in 2011 and 13. And what we seen here is this cholangiocarcinoma incidence, and it just dropped around this year, maybe 2000, and now maybe around here it's maybe dropped to 60 cases per 100,000 person years. So it's dropped, but we still see a lot of patients that come with a cholangiocarcinoma. So another way to control this is then now the government endorsed this program, the cholangiocarcinoma screening and the care program. So we never have the screening program for the cholangiocarcinoma. In here is because that in the Western country, the cholangiocarcinoma is kind of rare. But in our country, in Thailand, in my country, it's as the prevalence is very high, as the incidence is high, so we think that maybe we should propose the screening program for the people. And what they aim to do is they project to provide a long-term screening program for 150,000 patients. 100,000. This is going to be the high-risk individuals who have a liver fluke infection. And the thing is maybe we should have like a trial or a clinical study to prove that the cancer screening program for the cholangiocarcinoma. But I think the way that what we do now is the government just endorsed to do that, and then they're gonna found that what's going on in this cohort, and then maybe it can come out with the better cancer screening strategy. And also they want to set up the comprehensive cholangiocarcinoma care network in Northeast Thailand. Okay, so this is going to be my last topic is the fluke-related and non-fluke-related cholangiocarcinoma, if it really different between these two. Oh no. Okay, so here is this elegant study is done by collaboration between the Singapore National Cancer Institute and the Khon University. They just compare the OV-related cholangiocarcinoma and the non-OV-related cholangiocarcinoma, and compared by doing the exome sequencing, and it come out with this. So this is the one example that there are some difference between these two entities of the cholangiocarcinoma. This has been shown by the previous speaker already. that OV-related cholangiocarcinoma tend to have more TP53 mutation, SMAD4 mutation, while the non-OV-related cholangio tend to have more IDH mutation and the BAP1 and here the summary of the finding. So one thing that concern me is for the finding, I think that it's really different. But one thing that I didn't show the data, but if you remind that the data from MD Anderson from Dr. Jaffrey that actually the extrahepatic cholangiocarcinoma and intrahepatic cholangiocarcinoma here have some difference in the gene expression. And if you look this, in Thailand here, the Thai cholangio, they have a SMAD4, they have a TP53 KRAS mutation, more than a non-OV. And the ADH very rare to see in the Thailand cholangiocarcinoma or OV-related cholangiocarcinoma. The thing is more similar to the extrahepatic cholangio here. So this I'm not sure that what is going on, what is really the cause of the result. If it really the biology of the OV associated cholangio, or is it because that this also includes some extrahepatic cholangiocarcinoma. Back to this slide again. If you, as I have mentioned, the cholangiocarcinoma in Thailand, they define it in the cancer registry program as a liver cancer, and it's coded by the ICD-10. So that means when they say that it's an intrahepatic cholangiocarcinoma, they include both the intrahepatic cholangiocarcinoma and also the polyhilar cholangiocarcinoma, which we define it as an extrahepatic cholangiocarcinoma. So we don't have the nationwide data how much the prevalence of the intrahepatic and extrahepatic, but one report from the Konkan University is from the 400 patients, extrahepatic cholangiocarcinoma is around 50%. And it's just go along with our practice, because our practice we always see the hilar cholangiocarcinoma more than the intrahepatic cholangiocarcinoma in Thailand. Okay, and here what I have done in when I'm here with Dr. Jaffrey in the MD Anderson, we do the microRNA expression profile and compare it between the OV and non-OV cholangiocarcinoma. This work is supported by the Cholangiocarcinoma Foundation, and here that we compare the 10 OV cholangio and 10 non-OV cholangio and do the microRNA microarray. And here the purple color here is a OV cholangiocarcinoma, then the red color here is a non-OV cholangiocarcinoma. And you can see that it's a cluster, it's quite cluster away from each other. And we can define that 71 microRNA that differentially expressed between these two. And combine it with when we analyze with the normal dark compare it with the normal dark microRNA expression. So we come out with this that we can have 5 microRNA differentially expressed in OV cholangio compared to the non-OV cholangio. And we propose that maybe these 5 microRNA is a signature of the OV cholangiocarcinoma compared to the non-OV cholangiocarcinoma. But we just able to validate only this one, the microRNA 200C. Okay, so here I'm gonna conclude here that the liver fluke infection is a major health problem in Thailand and in Laos. And OV, Opisthorchiasis viverrini, Cholangiocarcinoma are the carcinogenic to human. Opisthorchiasis is a control is very challenging, and we need more effort to do that, and we need to rethink about what we have done in the past decade. And We believe that the fluke-related and non-fluke-related cholangiocarcinoma are different. But still now, we're still doing the same thing for these two groups. But we believe that in the future, we're going to treat it differently if we have more data. Thank you very much.
Biliary system, fasciola and ascaris, don't cause cholangiocarcinoma. So part one of my question is, what differences about where they live or what the inflammation is or the nature of the infection might be that would teach us about what the risk factors are for Clonorchis and liver fluke versus these other parasites. And then the other question is, you said there's a distribution of intra and extra and mixed. So does the fluke itself live in all portions of the biliary tree, and can we explain the distribution on where the fluke lives, or is there something else about that?
Okay, so for the first one, for the other fluke or other worm, that there's no data report about the cholangiocarcinoma related to that fluke. And also, as I have shown that for that the three common liver fluke, the Opisthorchiasis felinus have no reports of the cholangiocarcinoma, even though they have some animal models that demonstrate that the Opisthorchiasis felinus can cause the cancer, but there's no report of the cholangiocarcinoma in that population. So we believe that it's not just only the fluke. Maybe the fluke, these two, the OV and the Clonorchis, have more the carcinogenic effect, but also it's the habit of the people over there too, that they have more thing that to promote the cancer. And the second question, the liver fluke, the Opisthorchiasis viverrini, we know that it's habitat in the biliary tree, but usually it's in the large or medium duct, but in the liver. It's not extrahepatic. It's very rare to see the liver fluke in the distal bile duct or gallbladder or the pancreas. It's very rare. So, but the thing is, in the practice that we always see is most commonly patients have a hilar cholangiocarcinoma from this area, or even not a hilar cholangiocarcinoma. They're gonna confine in the proximal bile duct, not a very peripheral bile duct.
Yeah, thanks. I have three questions. How much fibrosis do you see in these livers? I mean, how strong is a periductular fibrotic pattern, and do you actually get prickable fibrosis?
I think these are the data from the Konkan University, but actually the fibrosis that they have shown they have done in the Opisthorchiasis pathology is usually from the animal and from the autopsy, but autopsy is just a very few patients. But the thing that they have extensively done is by the ultrasound. So they see that as depicted by that picture. They just see that the periductal fibrosis is just along the bile duct, but how much extensive they cannot demonstrate that. But one interesting thing that they have done is if you have this thing, the fibrosis on the ultrasound, and you treat it with a praziquantel, it's gone.
Yeah, so do they actually get a cholangiopathy? Do they actually get some sort of disturbances of the bile ducts that you can see on a cholangiogram?
They see on the cholangiogram too, but I'm not sure for this. They say they have done in some patients, very few patients, they do some cholangiogram and they see some change. But the thing is not the really change that maybe you see from the primary sclerosing cholangitis. It's not the thing that happened in the distal bile duct. And as I told that this may be not the fibrosis that irreversible. It can be reversed.
Yeah, but all fibrosis can probably be reversed at some stage. And then in the genetic studies, have they separated perihilar from intrahepatic? It's very confusing to me, the genetic studies that come out of Thailand. Have they separated those two entities?
You mean the polyhyla and
Yeah, have they classified them and then run the genetics?
no?
Right.
For that, the exome sequencing data, there's no data that is from the intrahepatic only or not. But as I told, because the specimen is from the Konkan University, usually the patient have they say they have an intrahepatic bile duct, but by their report, it's maybe around 40 or 50% that maybe the polyhyla cholangiocarcinoma, or even is a intrahepatic bile duct. I believe that it's maybe more proximal.
Okay. And then how many mixed tumors do you see, HCC and cholangiocarcinoma? Because HCC is quite common in Thailand as
Yeah.
well. So how do you see many mixed tumors?
No, for the mixed hepatocholangiocarcinoma, we see quite a number, but we have no data. Let's say that if we see maybe 20 patients of the cholangio, maybe you see one hepatocholangio feature in the pathology.
Yeah, that would be high incidence.
Yeah.
Thanks.
Hi, thanks for a great talk. I'm a little bit intrigued by the connection with the nitrosamines. And I'm wondering also, so it's recently shown that in South America, particularly in Chile, they actually showed very nicely that aflatoxins are associated with the development of gallbladder cancer. So is there any aflatoxin exposure in these areas in Thailand as well? Could there be a contribution?
Yeah, we in the past we have the aflatoxin exposure, and it's also the risk factor for the liver cancer.
Mm-hmm.
But they are aware of this confounding. So all of the data, they just exclude the effect of the aflatoxin already.
So is there a contribution of aflatoxin, or there's no contribution of aflatoxin to the cholangiocarcinomas?
For this area, no.
No. Okay. Thanks.
One quick question, one comment. The comment is that it's great to see the ecological changes that you're implementing in terms of getting the use of or the taking of fish down, but I wouldn't feel too bad about the fact that it's not going down that much. I mean, we still can't get people to stop smoking.
Yeah.
You know, and the fish tastes a lot nicer than the cigarettes.
I see.
So you know, it's still going to be there in 50 years' time. The other comment though was the TP53 mutations. Is there any indication that the mutation profile is different in the OCCA versus the non-OCCA?
Oh, I have no data about that.
Because although there may be a difference in incidence, actually it's which mutations that you see that may be giving you a characteristic fingerprint for OCCA.
Yeah, nice thought.
So Suebpong, some of the genetics that you described there, KRAS, P53, etc., we think they are probably bad players. So is the extrahepatic, is the type of perihylar cholangio that you see in Thailand, is the prognosis significantly different from what you see in the West, or?
The polyhyla, I see that the polyhyla usually have a better prognosis compared to the intrahepatic. I think pretty similar to here.
Yeah, you say it's intrahepatic, but it's really perihylar, isn't it? That's most of your patients.
Not most, maybe, but I'm seeing because you know I am in Bangkok, so but most of patients of the cholangio is come from the northeast. But I'm still have some patient from the my area and from the south. So we see both the intrahepatic and the polyhyla. But from the northeast too, we see both the intrahepatic and the polyhyla or hyla cholangiocarcinoma. But what I see in the northeast, I feel that the hyla and polyhyla is more than intrahepatic cholangio compared to other area.
So Ghassan, just to point out that he was our first fellow funded by the foundation and the Life Foundation, and we're really proud of the work he's doing there. He has access to a huge database through Konkan University and the network that he has. So I'd encourage you, Suebpong, to connect to Lewis Roberts and really some of the gastroenterology folks you have here to you have some collaborative work together with them.